So once they have a plan, this is the same, the final result of doing that contouring. This is the same patient, arms up, lungs, so this is the area of interest, then the margins that are put around it, and then the high dose radiation goes to everything here in white. Looking at it from the side, you can see that we're trying to limit dose that goes to the spinal cord, dose that goes to the front, and looking at it axially, you can see the tumor is here, this is the aorta, and everything below it we want to try to avoid. So we try to aim radiation to spare as much normal organs and tissue as possible. So as you remember, the 2D plan, the 2D picture that I showed you didn't have this conformity. They just put a block on there and aimed radiation at you. But this one you can envision a little bit. You know, they're trying to limit. It's not the big old block of what they're aiming at. So they're trying to limit, and it's more conformal. It starts, if you remember, it starts very tiny amount of treated area. Then it widens out where the tumor widens out. It narrows where there may not be any tumor, and it's specifically designed per patient. So nobody's plan is like the other person's plan. So once the beam angles are put on, this is what the prescription that we put into the machine. And when patients come to MD Anderson, they say, oh, the machine moves to the right and to the left 6 times, and I can time how many ticks there are between the machine moving. And this is what they're describing to their family members. You know, they aimed at me with this field first, and then this field, and this field. And typically they don't feel anything when they're on the table because it's just like an x-ray. But cumulatively, with time, they may get fatigue or they may get some sunburn of the skin. So with, again, MD Anderson trying to use the state-of-the-art technology, we're still always trying to limit the amount of toxicity that we have to have when we give our treatments. Before, like I said, we used CAT scans and we could outline where we thought tumor was. But if you can look, this also would be very suspicious. So we'd say, well, this is tumor. Perhaps all of this is tumor. Yes, we know this is heart. But with PET scans, a PET CT scan now that we can do that is a radio-labeled isotope, it can tell us, you know, specifically when we do it, this is the same patient, same scan, this is the active area, this hot spot. So it helps us spare. So rather than having to aim at all of this tail up here too, which is deemed inflammatory, then we only have to aim at this part. So we can limit, again, how much is near the heart, how much of the lung has to be involved. So this is how we use, this is a PET scan generated at the same time that the CAT scan was done, and then when we set up our patients, where those areas are. So again, we're limiting how much radiation we have to give. So all of this beam angle arrangement and trying to limit the amount of radiation that goes to normal tissue is called an intensity modulated radiation therapy, or IMRT. And bigger centers, MD Anderson uses IMRT, and it allows us to conformally custom target the areas that we have to treat and concentrate the highest intensity of the radiation at those targets, but spread acceptable doses, because there's fall off from radiation over critical structures that may be next to or in close proximity, you know, to areas that we can't avoid. So IMRT radiation, again, is one of those ways that we're trying to limit the amount of radiation, and this is a very fuzzy slide, but you can see that all those contours were done, and this was the interested area. Beam angles were put onto this, and you can see that even though this looks like it's right in the middle of the chest, when you look at it from the side, it's more posteriorly based, so we could try to miss a lot of the lungs that are towards the front. And again, looking at it from a CAT scan, this is the area that's treated, and this part here gets the high dose of, in this case, 4,500, but we want to limit radiation quickly to the areas around that. So even this purple magenta line is 3,000. This is 1,000 here. So we're always trying to limit the amount of radiation, because radiation can cause scarring, radiation can cause fibrosis in the lung, and make breathing worse. So when our patients with mesothelioma come and go through that big staging, are determined that they should have chemotherapy first to try to shrink their tumors, or perhaps then go to surgery. Like I said, extrapleural pneumonectomies are removing the whole lung on that affected side, removing the lining of the lung or the pleura, and testing the lymph nodes while the surgeon is in there in that big procedure Dr. Rice showed us last time. See what lymph nodes are involved, what areas are involved, and even our surgeon's very, very good at putting clips at where are questionable areas, or areas that might have had tumor left behind or might have been questionable, and it helps direct the radiation oncologist after that. That's where the clip is, that's where the doctor said the tumor might be left behind, so that we can concentrate radiation to those spots. And because the tumor is gone, the lung is gone on that side, we don't have to worry about the fibrosis or scarring. We can aim the radiation at the complete site of that radiation, of that affected mesothelioma. Our surgeons also resect the diaphragm many times. Dr. Rice is very good even at, there's a kidney on that side that we don't think about, but when radiation is given, you have to get very close to the kidney, and he even may tack the kidney down, anchor the kidney lower in the abdomen, so that when we're aiming radiation at it, we're not damaging that kidney more than we have to. But in cases where we can't avoid that, you know, we always do a renal scan first to make sure that the patient has adequate kidney function, that if we do have to sacrifice that kidney with radiation or scarring, that the other kidney could do the work that it needs to do. So this is one of the IMRT plans that is generated after an extrapleural pneumonectomy, and you can see that it kind of goes along with the very long, arduous procedure that Dr. Rice does. He dissects everything around this chest cavity, all here. He manually takes all this out, goes all the way down into the sulcus of the lung, and he and the radiation doctors would then get together afterward and work on this plan. He would tell them, he would start like at wherever areas of interest were, and they go slice by slice through every slice of the CAT scan. And he would say, you know, this was an area, this was an area, you know, we have to make sure that we hit that part with radiation. So then the plans are generated. So this is all the area we want to aim at, but this is liver here. This is kidney on the opposite side. You know, this is kidney on the affected side. So when they take together everything, this is what the plan looks like, and all the areas that we'll be aiming at. So the blue is the 4,500 centigrade that we typically give for radiation, and that usually is given over 25 treatments. Sometimes they'll go up to 50 if there are, and even these days 60 or 60 centigrade or 6,000 rads of radiation, because there might be areas at risk left behind after these surgical procedures. But if you can, it's hard to realize, but when you're aiming at somebody's body this way, there's a lot of things that get affected. The skin, the tissue, the ribs, the heart, the mediastinum, the lymph nodes. But one thing we don't have to worry about in this type of procedure, there is no lung there. It's an empty cavity. So we can give everything in between this area, the good dose of radiation to try to prevent that tumor from coming back. And the purpose of the IMRT is to try to still, even though we know we're aiming at a very big area, we still want to try to limit the amount that the liver might get. And the best way to do that is with an IMRT plan, because we can spread doses of radiation. All of these lines here, here, here are beam angles that are aimed at patients that will again conform to the areas of the tumor, but avoid the critical structures.